I'm Laura Mourafetis. I'm the Navy resident currently on service, and I'll be just briefly discussing adolescent idiopathic scoliosis with a focus on classification. So real quick, this is the agenda for my discussion. I really like medical history, so we'll talk a little bit about the history of scoliosis treatment, going back to ancient Greek times, talk briefly about prevalence, pathophys, and then go through the King and Lanke classification systems. So a history of scoliosis goes way back. The earliest descriptions of scoliosis go to Hippocrates. In some of his works, he described both the normal curves of the spine with the lordosis of the lumbar and cervical spine, and he also described scoliosis and recognized its association with things like tuberculosis and hip dysplasia. His treatment, you can see on the right, was mainly focused on manipulation. So this was the Hippocratic ladder, where you'd strap the patient to it and then shake them, and you'd either do it right side up or upside down, depending on where the deformity was. And then jumping forward to the more modern surgical era, Russell Hibbs in 1911 published a case series of patients where he did long uninstrumented fusions. So to do this, he would do fascectomies, he would remove their spinous processes and use those as bone graft along the spine. And then they would need long periods of casting. As you can imagine, these had pretty unpredictable results with high pseudoarthrosis and infection rates. And then in 1962, Paul Harrington published his case series. Not long uninstrumented, but he was the first to use implants for scoliosis correction. And his method used concave distraction with a ratcheting stainless steel rod, and then later on added a convex compression rod as well. Still very high rates of complications, but obviously an important breakthrough. And then the 1970s to present saw multiple advances in the areas of a greater understanding of the 3D correction of the scoliotic deformity, as well as increased stability of constructs used. So some important definitions from my level to determine whether the patient has scoliosis or not. You look at their Cobb angle. So Cobb angle greater than 10 is scoliotic, and less than 10 would be spinal asymmetry. There are three types of scoliosis: congenital, neuromuscular, and idiopathic. Idiopathic being the most common. And again, we'll focus our efforts on idiopathic, and within that on adolescent. So prevalence of AIS. AIS is more common in females, and interestingly, the female to male predominance is more noticeable the larger the curve is. So there's not a big difference for small curves like 6 to 10 degrees, but as you get larger and larger, that sex-based difference becomes greater, especially for those curves that necessitate intervention. So briefly on the pathophysiology, the underlying cause of AIS is still unknown, even though multiple theories have been advanced. These include genetic, hormonal changes, deficits in proprioception, likely multifactorial, but no one's really pinned down the exact cause. And as I talked about briefly for medical history, a lot of the newer advances in scoliosis come from a better understanding that it's a three-dimensional deformity. So one thing that I learned doing this talk is the rotational deformity. So the vertebral bodies rotate towards the convex side of the deformity, while the SPs rotates towards the concavity. And the rotational changes are greatest at the apex of the curve. And then one thing you can see in the growing scoliotic spine is that compression and distraction forces result in wedge-shaped changes of the vertebral bodies. So they'll be higher on the convex side and lower on the concave side. All right, so then we'll get into the kind of focus, which is classification of AIS. To do this, we do need a couple more definitions. So one important one is the apical vertebra. This is the vertebra that's deviated most laterally from the central sacral line. So the central sacral line bisects the sacrum, and it's perpendicular to a line across the iliac wings. So the vertebra that's farthest laterally from that is the apex vertebra, or the apical vertebra. And then you have your upper and lower end vertebra, which are the vertebra tilted maximally towards the concavity of the curve. A couple more useful things are the neutral vertebra. This is the vertebra without any rotation, so looking straight on to the pedicles. And the stable vertebra is a very important concept. And that, again, you look at the central sacral line, and it's the vertebra that is most closely bisected by that line. So starting with the King classification system, or the King-Mo classification system, this was published in King's 1983 review of the results of spinal fusion for scoliosis. And it was based on, the surgeon was John Moe and his experience with Harrington rod instrumentation specifically. So he divided curves into 5 types, and based on that had recommendations for which levels should be fused based on the curve type. Important radiographic concepts for the King classification. Stable zone of Harrington is you draw 2 vertical lines through the lumbosacral facets going up, and all the vertebra in that shaded area are in the stable zone. And then King and Moe kind of outmoded that and instead used the central sacral line. And again, looking at which vertebra that bisects, or the stable vertebra, as an important concept for figuring out where your lowest instrumented level of fusions would be. They also talked about flexibility index. So just looking at the percentage correction of the thoracic and lateral curves on your lateral bending films, and then you take the percent correction of the thoracic curve, subtract it from the lumbar curve correction, that gives you flexibility index. So a positive flexibility index would mean that your thoracic curve is more flexible. So then you take all that and you can put your scoliotic curve into one of 5 categories. So type 1 would be a double curve. So both the lumbar and the thoracic curve cross midline, but the lumbar curve is stiffer. Type 2 is, again, a double or S-shaped curve, but the thoracic curve is stiffer. And then 3, the thoracic curve crosses midline, but the lumbar curve doesn't. And then 4 is a long thoracic curve where the L4 vertebra is starting to tilt into that curve. And then finally, I don't have an x-ray of it, but L5 is just a double thoracic curve where L1 is starting to tilt into that upper thoracic curve. Then he gave recommendations based on that classification. So if you have a type 1, the recommendation is to fuse both of those curves, but don't go lower than L4. And then basically 2 through 5, the recommendation was fuse to the level of the stable vertebra. And then this classification has been kind of bypassed because it was developed in the era of Harrington rod instrumentation, but it doesn't reliably predict responsive curves that are corrected with more modern segmental instrumentation systems. So as a result, we instead have the Lenke classification system. So this was described in Lawrence Lenke's paper from 2001. That's this paper here, a new classification to determine extent of spinal arthrodesis. This is what the Lenke classification system looks like. And we'll briefly go through the steps to assign a Lenke classification. So there's 3 steps. The first step is to identify and then classify the primary curve. So you're going to measure the curve at each level. So that's at the proximal thoracic, main thoracic, and thoracolumbar or lumbar level, and it tells you here, which apex you're looking at for each of those. And then you identify which of those curves is the biggest, and that's going to be your major curve. And then now that you have your major curve, you figure out if the minor curves are structural or not. So the structural curves would be they have a greater than 25-degree deformity on the AP, and it doesn't correct to less than 25 degrees with bending. And then based on that, you can figure out your curve type, and it's either 1 through 6. So 1 being a main thoracic curve. Type 2 is a double thoracic curve. So you have a major main thoracic curve, and then a minor proximal thoracic curve that's also structural. And then type 3 would be a double major curve. So you have a structural main thoracic as well as a structural thoracolumbar lumbar curve. And then triple major, all 3 curves are structural. 5 is your structural curve is thoracolumbar lumbar. And type 6 is you have both a structural thoracolumbar and a main thoracic curve. And those are your types. So not too bad there. And then once you've done that, you just need to figure out your modifier for your lumbar spine, which in Lenke's view is very important for figuring out lowest instrumented level of fusion. So to do that, you are going to either get A, B, or C, and you look at the relationship between the central sacral vertical line and the apical lumbar vertebra. So just to revisit, the central sacral vertical line is like pretty much the same as the central sacral line that Mo talked about, except you're not using the iliac wings. It's just a vertical line that bisects the sacrum. And then you're looking at where that bisects, or where that intersects, I should say, the apical lumbar vertebra. So if it hits it between the pedicles, that's an A. If it's a B, it touches the pedicles. And then a C, it's not even touching, it's completely medial. And then this is just going through it so you can see a little bit better. So this is an A, looking at the apical vertebra here, and you're hitting between the pedicles. And then here, B, you're touching the vertebral body or the pedicles. And then C, you're not touching that apical body at all. That's what those look like there. And then finally, you have to look at your kyphosis level. And so you get a Cobb angle from T5 to T12. And then you assign a modifier based on that. So if it's less than 10 degrees, that's negative or hypokyphotic. If it's 10 to 40, that's N or normal. And if it's greater than 40, that's positive or hyper. You can put all that together and you get your Lenke classification. And then, people have looked for, ever since that paper has been published, looking at putting together Lenke classification with how do you choose which levels to fuse. I think that's a little bit beyond my level and the length of this talk, but basically it helps in the important choice of upper and lower instrumented vertebra. So these are references. And then these are on the right, that's my boys at home. And the one on the left is the one I carry around with me all day. That's it.
That's awesome. That was great. Great ending. So the Lenke put that classification together really for one purpose, which was to determine which levels should be fused. So that was the whole point. The nice thing is it gives you a guideline on what to do. There now that thousands and thousands and thousands of cases have been done with that classification. Like the reality is that there's times where you can break the rules and times where you can try to cheat the system a little bit, et cetera. But his main thing was, if it's a structural curve, you fuse it. Right. If it's not structural, then you can leave it, and hopefully it should respond pretty well. Right. To what you do. So like that's the, like everyone's always like arguing about UID and LID and all that. The reality is span the curves that are structural and you're going to be fine. Right. And then most of us are always trying to do less, right? We want to save fusion kids. So that's where I think it gets a little more controversial and trying to say, hey, is there a place for doing like selective thoracic fusions in those that have, a lanky, 3 or 4, for instance, are we 6? Is there a way to not fuse some of those structural curves and leave them typically, lumbar flexibility as the main one that you're trying to preserve. So, and then if Dr. A was on, he would talk to you about the King Mo classification. And I still think it has value because I think they did a decent job of really looking at just overall balance. And I think that was kind of the main gist of theirs. The problem is they didn't take into account any of the sagittal plane. So I know that was one of the downsides of that classification. Anyways, great job.
Thank you.
Any other comments? Steve just trained with Larry. Steven did.
Oh.
I was just, it's funny because he never referred to it as his own, he never would say this is a lanky one or anything. But do you ever think that they'll, in a newer iteration in the future, they'll start to involve, L1PA or PILL even for the kids? Like,
yeah, because the whole the whole sagittal plane, even in this classification, is quite arbitrary, not really based on data. But I think if there's room for anything, it's to maybe fix that piece because it may determine how aggressive you are in the coronal plane.
Yeah.
Everyone loves showing their straight X-rays in the coronal plane, but most people are not doing a very good job in the sagittal plane. So
yeah,
I think you're right. I think it will evolve over time.
Yeah, I think in the adults now we've kind of pushed, into the extreme like sagittal plane stuff, and so I just wonder when that'll trickle down and start to care more because like you said, you see all these scolies that are fused, and you look at the lateral one, it's like, oh my god, like when are we going to fix that when they're adults, right? Like how long?
Yeah, the good news is we're not creating lumbar flatbacks as much as they did back in the day. So I don't know if we'll ever be doing like thoracic reverse PSOs, to create thoracic kyphosis. I don't know. I can't imagine there being an indication to do that. I think it's going to be like, hey, you got this, the thoracic spine is what it is, and then just modify what's below it for that purpose.
Yeah, I think it'll be our lifetime where we start to see kind of those new issues, right?
Yeah.
Cool. Or bad, but cool.
All right. Great job, guys. Have an awesome week.